third speaker is Dr. Mohammed Tahir. He's holding American board certification in internal medicine and cardiovascular disease, working in a private sector in St. Louis from the United States of America. He's going to talk to us about the heart score.
Morning, Assalamu alaikum. It's a pleasure to be here. The topic I was given was a heart score. Interesting one. And I didn't know where to start, how to start. So that's where I would start the heart score. The first thing I would say is that about 6 million visits in the emergency department every year in the United States. A lot of people. So with this context, we're going to talk about, I thought I'll start with a case history and see where we lead. 30-year-old male patient presenting with a left-sided chest pain of acute onset. Moderately severe, worse on movement, no family history of heart disease. He's on no medication. His exam is unremarkable, and the EKG shows a sinus rhythm. There was nothing else which was very exciting on that EKG, which would have given cause for concern. The troponin was less than 0.3, 0.03. These are, I gave a troponin talk yesterday, and all these numbers are very, very different depending on what assays are using. So in our emergency department, this is a normal value. So I hope you would remember all these case histories in the end when I go back and talk to them. This is another one, a 45-year-old patient. She presented to the emergency room with a generalized chest pain, which was sharp in character, worse on movement. She was nauseated. The pain had lasted quite a long period of time. She had no shortness of breath. She was not diaphoretic, and the exam was normal. There was some chest wall tenderness. The sinus rhythm was there on the EKG, and there was some non-specific ST and T wave changes. Troponins were less than 0.03, and she was on no medication. And that's the last one of the case history. 60-year-old male patient, hypertensive, diabetic, hypercholesterolemic, substernal chest pain, burning in character, nauseated, diaphoretic, no past history of MI, a blood pressure of 160 over 100, a heart sounds which was normal. He had an ST depression of 1 to 2 millimeters and a troponin of 0.20. So with this, so they are in the emergency department, and one of the things which the ER physician has to do is to stratify and see what has to be done. Now, these are real case histories. These are all the 3 patients. I very recently saw them in the ER. So coming back to this score, what is it? So the first thing is a history. Is it highly suspicious? Is it something, as you're taking the history, you think that this could be secondary to cardiac ischemia? And if it is, there is a score of 2. If it is moderately suspicious, you give a score of 1, and if it is slightly suspicious, you give a score of 0. EKG, significant ST depression of 1 to 2 millimeters would be a score of 2. Non-specific repolarization changes, you give a score of 1. And if it's normal, it's 0. Age, very significant, this is 65 or greater, it's a score of 2. Between 45 and 65, it's 1. And if it's less than 45, it's a 0 score. I went through this score, and I have seen patients with the age, in the ages of between 25 and 27 presenting with acute MI. So yes, once the age is less, you become less suspicious, but it's not a done deal. You have to be very careful. All the risk factors, I'm sure you know, hypercholesterolemia, hypertension, diabetes, cigarette smoking, positive family history, and obesity are all risk factors. And they all have scores. If there are 3 or more risk factors, it's +2, 1 to 2 risk factors, 1, no risk factors, it's 0. Troponins, a rise of grade 3 or greater of the normal limit, a score of 2, 1 to 3, it's 1, and if it's normal, it's 0. So what are the pearls and pitfalls of all this? Since it only involves the first troponin on admission, it can be normal. It also depends how long the person has had chest pain before he came into the emergency room. So the rest of the scores, they're based on age, history, risk factors, and EKG. So the low-risk patients have a score of 0 to 3 and have less than 2% risk of MACE. MACE stands for all-cause mortality, acute myocardial infarction, and coronary revascularization. Now, all of the scores are high risk and require further management. So any ED patient with chest pain, the physician deems appropriate for ACS workup. At the end of the day, it's the person who's seeing the patient makes the decision in spite of all these scores. So, okay. So if you remember the first patient of mine, the young person who presented with musculoskeletal pain, with no other risk factors, a normal score, a normal troponin, and a normal EKG, where would you put the score, and say to that patient, generally? So I thought that there was a low, the score was between 0 to 3. It would have been safe to send that patient home. Would you agree with that? Anybody who doesn't agree with me? The second patient of mine, the one which I presented, was rather a little atypical one, did not follow the rules. The burning pain was there. She had no the troponin was normal, the EKG was not showing anything. Now, that was a patient. I sat in the ER for about 10-15 minutes to figure out what was happening and what we should do. So in the end, I just thought that something was not right. It didn't follow the score, and I admitted this patient. So 4 hours later, her troponin was 5. So the burning pain still persisted. There was no other EKG changes. Nothing else happened. I did an echocardiogram. There was no wall motion abnormality. So we thought, fine. It was the middle of the night. Tomorrow morning, we'll cath her. The pain persisted the whole night. I started her on IV heparin. There were no EKG changes, but the pain was there, and it was still, on a 5 to 6 on a scale of 1 to 10. So the next morning, the troponin was 15. By the time we took her to the emergency room, her LED was occluded. And so it was difficult, what to do. So she had the LED open, everything was fine. She went home the next day. So although, the heart score there was, according to whatever the numbers were, was a low score, but there was something there which was a little concerning. And that is something which will always be confronted to an ER physician or when you're sitting in the emergency room and you're making decisions. So these scores are there, but at the end of the day, it's the clinical judgment which matters. So the last patient actually was admitted. His score was high anyhow on the presentation, and he got a cardiac cath, and he went on and had a bypass surgery. So there where we are, so a low score is 0 to 3 points on the score risk which I gave you. The risk of MACE is between 0.9 and 1.7%. So it's a very low risk, but still there. These patients can normally be sent home. And anything where it's a moderate score or an intermediate score, the risk of MACE increases significantly to 12 to 16%. And with a higher score, this is where the risk is of 50 to 65%. Any questions?
Question at the end.
Thanks.